Well, this is the September 2024 MEC Minute. We're going to talk today about sepsis. And I look back at the past 8 to 10 years of doing MEC Minutes, and I don't find any previous conversation regarding sepsis. So I think it's time we have that conversation. And the reason I think we need to have the conversation is sepsis is a big deal. We have a lot of patients who have infection. Sometimes it's something inconvenient like strep throat or maybe flu, but sometimes it's a life-threatening bacterial infection that requires early recognition, aggressive treatment, and intravenous antibiotics. And the impact and cost of sepsis is significant. Only over 970,000 hospital admissions per year in the United States, and the incidence of sepsis is going up. So it's increasing by almost 10% a year over the past 20 years. And that's probably because we're having an aging population. We have a greater number of older people who are more susceptible to sepsis. They have had more chronic predisposing illnesses to sepsis, and they may even have had indwelling devices that can get infected. Really, sepsis, according to the CDC, accounts for 1 in 3 hospital deaths. So of all people who die, about 1/3 die from sepsis. And across the world, sepsis is involved in 1 in 5 deaths, and that's according to the World Health Organization. The mortality rate for patients with a diagnosis of sepsis on admission is 12.5%. If the patient's admitted and then has a later diagnosis of sepsis while in the hospital, their mortality rate goes up to 25.5%. Why is that? Probably because if the patient is diagnosed with sepsis early, then they're going to get aggressive treatment sooner. Whereas those who come in with some oddball symptoms, something that doesn't specifically point towards sepsis, they may go hours to days before they are diagnosed with sepsis or an infection and started on appropriate antibiotics. And this costs a lot of money in terms of cost of care for patients with sepsis. So in 2021, that number was estimated to be $62 billion just in the United States. And that represents about 13% of total healthcare costs, while only about 3.6% of hospital admissions. So if you again, just for a point of comparison, sepsis is about 3.6% of our hospital admissions, but it accounts for 1/3 of our in-hospital deaths. So that mortality rate is greatly disproportionate to the number of septic patients who are actually admitted to the hospital. So something to keep in mind. So this is really quite alarming, and we as EMS providers provide initial care for up to 50% of the patients in the emergency department who are diagnosed in ED with sepsis. So we bring in a lot of patients who are found to be septic, and this includes most high acuity patients with septic shock and those who are ultimately die. So what does that say? It says that as EMS providers with increased awareness and aggressive treatment may have an influence on the patient's outcome. And this is your opportunity for identifying sepsis and starting the early diagnosis and care. We all know that the sooner patients are treated for these time critical events, the better they do. So speaking of time critical, we used to talk about the big three time critical events. Trauma was the first. That was probably back in the 80s. And then in the 90s, we started looking at MIs because we had aggressive treatments for patients with MIs. And the EMS was able to do pre-hospital 12 leads. So MI became the second. And then within the past 10 years or so with thrombolytic therapy and interventions, stroke became the third time critical event that we pay attention to, particularly for EMS providers and emergency departments. Well, now sepsis is number 4. And it's not that sepsis just became known to us. It's more that we've become more aware of it. The mortality rates are going up. The number of patients admitted with sepsis is going up. All the things that I talked about in the earlier slides. So you should consider sepsis a time critical event. And we'll talk in a little bit about what you need to do and what you need to think about to identify sepsis, or at least consider sepsis and initiate care early. Just some numbers. I think these are kind of impressive. If you look at mortality rates of all those things listed, sepsis has a mortality rate of around 21%. Let's just say 21%. Respiratory failure, a little bit less than that. Myocardial infarction of 11%. Stroke is about 7%, and so on. We have other ideas, other things. Patients come in with COPD exacerbation or DKA or pancreatitis. Uh, Good number of patients, but they are much less likely to die on that admission than septic patients. So sepsis patients, really, a diagnosis of sepsis on admission really puts you at high risk and at a higher likelihood of dying during that hospitalization. So how deadly is sepsis? Here's another perspective. Despite all our advances in treatment of infectious diseases, sepsis kills more people than myocardial infarction or any of the common cancers, such as lung cancer, colon cancer, or breast cancer. So, we focus a lot on cancer risk reduction and treatment of cancer. We spend a lot of time raising money for cancer treatment and research, but sepsis still kills a lot more people than patients who have diagnosis of cancer. So we really need to think about how we can improve our pre-hospital care of patients with either presumed sepsis or sepsis. So comparisons, severe sepsis had a greater mortality rate than stroke, breast cancer, lung cancer. And if you look at the levels of sepsis, which is sepsis, severe sepsis, and septic shock, patients with septic shock are fewer in number but have a much higher mortality rate, between 40 and 80%, depending on whose numbers you look at. And their average cost of care is almost two-thirds more than that of the patients who are septic without septic shock. So just to give you a sense of perspective, patients who present with sepsis but without severe sepsis or shock, 10 to 20% mortality rate, and it only goes up from there. And the cost of care goes up, and look at the length of stay. A patient who's got sepsis without septic shock or severe sepsis has a length of stay about 4.5 days versus septic shock, if they survive, has close to a 17-day length of stay in the hospital. That's expensive. Patients require a lot of care, and they're taking up beds that could be used for other patients with similar needs. So we have to think about septic shock and how deadly it is and how much it costs. Who's at risk for sepsis? Well, the elderly, I mentioned that. The extremes of age, the very old and the very young. If you think about a 1-month-old with a fever, that 1-month-old with a fever is septic until proven otherwise, just like the 80-year-old with fever is septic until proven otherwise. Diabetics are increased risk. Diabetics have impaired immune function, and they are more likely to get infected. They also are more likely to have wound infections and so on that predispose to sepsis. So think about the patient with diabetes who's got the infected toe because they can't feel what's going on in their toe, and now they've got an infection, maybe osteomyelitis, and they're not aware of it. That can then seed their blood system, and they can become septic. So diabetics are at risk. Patients who were recently treated for infection are at risk for recurrence. And the other thing about that is if they come back with a persistent or recurrent infection, the organism may be resistant to those antibiotics that were administered to the patient on the first admission. Recent surgeries at risk. The patient had their gallbladder out. Patient had an appendectomy. Patient had some other surgical procedure, maybe a bowel resection. They are at risk for infection and complications. Anybody who is on chemotherapy, so patients who receive chemotherapy for whatever cancer they might have, chemotherapy reduces their immunity, makes it easier for them to get infected. Their white blood count can be severely diminished, and they are also more susceptible to some of the unusual organisms that could cause infection. Patients who are otherwise immunocompromised. So it's not just chemotherapy. Chemotherapy compromises your immune system, but patients could be on other medications. Like last week, I had a patient with apparent appendicitis, but he also had inflammatory bowel disease and was on Remicade. And the Remicade impaired his immune system, so he didn't respond as well to the infection, to the appendicitis, as if he had a normal immune system. So, he ended up having a more complicated hospital stay. He required more aggressive surgery and so on. Steroids, long-term steroid therapy also can suppress your immune system. So if you think about your chronic lungers who are on chronic steroid therapy, they are at a higher risk for developing sepsis. And then anybody with chronic indwelling devices, so a Foley catheter, PICC lines, dialysis catheter, peritoneal dialysis catheter. Those devices effectively bypass the protective processes that our body has to prevent infection. So as soon as you put a Foley catheter in, it's much easier to get a bladder infection. As soon as you put a PICC line in or a dialysis catheter in, it's more likely to cause infection. Things like dialysis catheters and PICC lines are also manipulated, every day or several times a week. And every time somebody does something with that catheter, it's possible that you can introduce infection to the catheter, and the catheter gets seeded, and now it's a source of infection and sepsis. And then patients with open wounds, whether it's somebody with diabetic foot or somebody who's had some other healing problem, somebody with a wound vac in place because they had a abdominal. If you look at sepsis, it's really kind of a continuum. Uh, it starts with a fever, low-grade infection, and it gets worse. And when we start talking about identifying patients who may be septic, we have to think about SIRS. So SIRS is an acronym for Systemic Inflammatory Response Syndrome. We've been talking about it in the medical world probably for about 15 years now. And really, if you look at it for SIRS, the criteria are temperature higher than 100.4 or lower than 97. So patient, particularly the elderly, can be hypothermic. Patient with a heart rate greater than 90, respiratory rate over 20, and patients with a white count greater than 12,000, or if they're on chemotherapy drugs or steroids or other immunosuppressants, a white count under 5,000. Now, we use sepsis or SIRS criteria as part of our protocol. We don't include white blood count because in the field we can't measure that. But if you look at our algorithm, which I'll get to, we use the first three of these markers. There's another way you can look at it. Some people suggest use something called QSOFA, which is quick sequential organ failure assessment. There's something called SOFA without the Q, which is much more of an extensive evaluation, requires lab work and so on. But it's been suggested that we use QSOFA for EMS, and that's got three indicators. So it's hypotension with a BP less than 100, altered mental status, and then fast respiratory rate over 22. If you have a score of 2 or more, you're at risk for worse outcome. So really, QSOFA has been advocated by some to be a screening tool for EMS, but the problem is it's really been studied as a predictor of outcome rather than a screening tool for sepsis. So if you have a QSOFA of 0, your mortality rate's less than 1%. If it's 1, then you're having a mortality of 2 to 3%. But if your QSOFA is over 2 or more, then your mortality rate is at least 10% or higher. So QSOFA is out there. Don't really suggest using it at this point. Stages of sepsis. This is how we look at it. When I admit a patient, they're either septic or have severe sepsis, or they have septic shock. For sepsis, the criteria is the SIRS criteria, which I mentioned, plus a known or suspected infection. It's kind of interesting with patients who just look at these indicators. Half the lobby at the emergency department on a February afternoon or evening, half those patients probably meet SIRS criteria for sepsis. So you have to think about it. Is this viral or a bacterial infection? Severe sepsis is a patient who meets sepsis criteria but has progressive disease to include organ dysfunction. So this could be patients who have acute kidney injury. They have evidence of liver injury and so on. So it's or they can even have cardiac dysfunction, even have a non-STEMI secondary to the sepsis. So severe sepsis is patients who are septic, but they also have acute injury to one or more organ systems. And then septic shock is patients who are septic and they have organ dysfunction and now have gone to shock. So they're hypotensive, tachycardic. They look like they're circling the drain. So those are the stages of sepsis that we talk about. And then here's that continuum. Start out with SIRS. Your temperature's over 38 degrees or less than 36 degrees centigrade. Your heart rate's up, your respiratory rate's up, and you can also use a PCO2 as a surrogate for respiratory rate of less than 32. If you look at our protocol, we have a threshold of 25, and we use that for different reasons, but I'll talk about that. And then there's also the light count of 12, greater than 12 or less than 4 or less than 5, but that's not something for us as pre-hospital providers to worry about. Unless the patient's got lab work from the nursing home that was just drawn that morning. That might make it easier for you. So patients who are septic, they have SIRS plus evidence of bacterial infection. Severe sepsis is sepsis plus evidence of organ damage. Usually it's kidneys or liver. And then severe sepsis or septic shock is severe sepsis plus hypotension. So what symptoms might your patients have? They could be shivering, have fever, be very cold. They can complain of extreme pain or general discomfort. Sometimes patients will come in and they just ache and hurt all over. And then it falls on us to determine, is this a viral infection or is this a bacterial infection such as pneumonia or UTI that is giving these feelings. Patients can appear pale or discolored. You think about the patients who you see that are mottled, looks like they're not perfusing their extremities. Patients can have altered level of consciousness. They could be difficult to arouse and confuse. That's concerning. It could be because of hypotension or just because of their underlying metabolic status. I have a lot of respect for people who come in and say, I feel like I might die. Many times when patients say that, they're predicting the immediate future and they're pretty accurate. So I have a lot of respect for patients who tell me they feel like they're going to die. And then the last is shortness of breath. And patients could be short of breath because they have pneumonia, or they could be short of breath because they're tachypneic and breathing fast as a way of compensating for the acidosis they've developed as part of their sepsis. So those are symptoms. Here's some physical findings. Hypotension. When the patient is hypotensive, we know they're in trouble. Tachycardia, often a response to the hypotension or to fever. Altered level consciousness. If the patient is able to tell you, you might find out whether or not they're putting out the usual amount of urine. If the patient is really sick, we'll put a Foley catheter in because the Foley catheter gives us immediate output. We know how well the kidneys are being perfused. Patients could be having seizures. And again, patients could be either hypothermic or hyperthermic. So a patient who's severely septic may have a core temperature of 94 degrees, or they could have a core temperature of 103, 104. It just depends on how they're responding to the infection. So why do patients die? The more organ systems that are involved, the higher their risk of dying. So on the top, the numbers 1 through 7, those are the days since they first became ill. And then on the left column, you see the number of organ systems that are involved. So patients who have 4 or more organ systems involved, their mortality rate in the first day is close to 100%. And you can just kind of follow the numbers out. On the bottom right, I've got just a little diagram showing the different organ systems that can be involved. We typically look at the kidney and liver, but patients could have other parts, such as pulmonary disease, their endocrine system. So your blood sugar may be well controlled, but now it's 400, along with their fever and sepsis. They can have decreased cardiac contractility, and they just may not be able to circulate the blood because of pump failure. So all the different organ systems can be affected as part of sepsis. Just want to throw this up there. This is what we live and die by in the emergency department. It's called SEP1. It's Center for Medicare and Medicaid Services Sepsis Bundle. And this is how the hospitals and the physicians are judged in terms of treatment of sepsis patient. SEP1 is controversial, but we have to live with it. So the metrics that we're held to, and this is all or none, we have to hit all of these, is we have to measure a lactate within 3 hours. We have to get blood cultures prior to antibiotics being administered and do that phlebotomy within 3 hours. We have to give broad spectrum antibiotics within 3 hours. If the initial lactate is over 2, then we have to repeat the lactate within 6 hours. So when I see a patient in the hospital, I think they're septic, I order a lactate at the time of the first blood draw, and I order a redraw in 2 hours just so that it's done and we help meet this bundle. If there's a septic shock, then we have to give the patient fluid bolus, either ringers or normal saline. We use vasopressors to get the mean arterial pressure over 65 within 6 hours. Um, if there's persistent hypotension after the bolus, I have to admit that a lot of us are using vasopressors sooner. We're not waiting to see if 30 per kilo of fluids makes a difference. We may start them on pressors sooner rather than later. And then we have to document volume status and tissue perfusion with vital signs and so on. And it all takes time. And it's a lot of work. So as I mentioned, the hospitals live and die by this bundle. It's all or none. It is controversial. There's a study done by Townsend that suggested that if the bundle was followed, there was a 5 percentage point reduction in the 30-day mortality in Medicare patients, and it reduced the length of stay by a day. Well, this is controversial. His methodology has been questioned because he didn't break it out based on sepsis versus severe sepsis versus sepsis. He just kind of bundled everybody together. And so his methodology may have been prejudiced one way or another. Other studies have shown that following this bundle increases the amount of lactate testing, increases the number of or volume of fluid given and IV antibiotics, but did not make a change in mortality. But again, this is what we live and die by at the hospital, which is why we do some of the things in the field. What can we do about it? We can help by identifying patients early and getting the process started. So how can we help to reduce mortality? We have to have a high index of suspicion. Patients comes from a high-risk situation like a nursing home. Patient's got Foley catheter in. Patient has had recent surgery. Anything that puts the patient increased risk for sepsis, consider that a red flag. And then as you're transporting the patient, call for a sepsis alert. What sepsis alert does is just like calling for trauma alert or STEMI alert, it mobilizes the system so that we're better able to get things started when you arrive. Because we've seen that the sepsis mortality increases by 8% for every hour of delayed treatment. So we want to get this done early. We want to, in the field, expand effective blood volume with a fluid bolus. So many of these patients, when they're septic, it's a distributed shock. They have the same amount of fluid in their body, but their blood vessels are just dilated. So they're hypotensive. So start the fluid bolus. With the fluid bolus, you do also need to make sure the patient is not in heart failure or has some other problem going on. But if the patient appears to be septic and is hypotensive, get the fluid started. Start pressors. For us, it's an epinephrine drip. For the hospital, we use norepinephrine or Levophed. We don't use pressors enough in the field to justify adding norepi, so we're going to stick with epinephrine for now. Start your hemodynamic monitoring. These patients for you probably ought to have blood pressure checked every 5 to 10 minutes. You definitely should have one at the time of arrival on scene and one during transport and one on arrival on hospital campus. We need to see how the patient's responding to treatment. You can help start with that early goal-directed therapy, which has to do with IV fluids and getting the pressure up, starting pressors if indicated. And then also, any way we can affect early treatment and transport, the better. So here's what our protocol looks like. And just to make it easier I'll blow up the important part. So, we want to initiate treatment for sepsis if all three criteria are met. We have an infection that's suspected. Patient's got fever, heart rate, or respiratory rate. We'll take 2 of those 3. And if the end tidal is less than 25. So the end tidal less than 25 is a surrogate for a serum lactate at the hospital of 4 or more. That's been shown by studies. So we can't do lactates in the field, but we can use an end tidal as a way of estimating what the patient's lactate is. If the patient is not in acute pulmonary edema or does not show overt signs of heart failure, we should start a fluid bolus at 30 per kilo and give it quickly. Just hang it and run it up. Check the patient frequently for any evidence of heart failure, and just see how the patient does. As you're transporting the patient, initiate a sepsis alert as part of your radio report. That will get everybody's attention. And then if the systolic blood pressure remains less than 90, for our protocol, we're going to either start them on an epi drip or go with push dose epi. I've got a slide on that in a moment. So it's something to think about. Aggressive pressor use may be indicated depending on the patient condition. We're also doing a trial right now, and you may have heard this. We're doing this with less licking with 401s and 404s. We're starting to do blood cultures in the field for patients who meet criteria. And for patients, after the blood cultures are drawn, we're going to give them a dose of IV ceftriaxone or Rocephin. Um, if you look at the number one organism that causes sepsis in the healthcare system, it's a germ called E. coli, far and away the most common source of infection. And about 90% of E. coli infections are sensitive to Rocephin or ceftriaxone. And so that's what we're going to use. There's one that's a little bit better than that. It's called Zocin, but it's a penicillin product. And you have to think about patients with penicillin allergies, whereas with Rocephin, there is no risk for allergic reaction in a patient with documented penicillin allergy. So we're going to use Rocephin. If this trial goes well, we will expand it to other trucks. We will also offer it out to other healthcare systems, see if they want to participate. Just a quick note of EpiDrip and push dose epinephrine. I would like you to review the protocol and become comfortable with it. On the left is our chart that we put together to help you dose the medication. The drops per minute is based on a mini set or 60 drops per minute administration set. Whether you're going to use push dose epinephrine or epinephrine infusion, it's the same mixture. You take one vial of 1 to 1,000 epinephrine, which is a milligram, and you put it in 100 milliliters of normal saline, and that's what you use. And that gives you 100 micrograms per ml. So you can either do an epi drip, and per protocol, you start about 2 micrograms per minute or 12 drops, and you titrate every 5 minutes. If you want to use push dose epi, that's okay as well. So if the patient is hypotensive, you've got the drip mixed up, pull up 1 or 2 cc's of the epinephrine and push it, administered IV push over about 30 seconds. The nice thing about push dose epi is you can redose if you have to. You may get a quicker response in terms of patient response, better improvement in blood pressure with the push dose than over the epi drip, and you don't have to worry about titrating it. It's your choice, but you need to be comfortable using this medication. Finally, in summary, sepsis is a deadly disease, overall mortality of over 20%. Early treatment requires high level of suspicion. It's been shown that as clinicians, our gestalt, particularly if you've had a good street time, good experience, you've been out for a while, your gestalt, your gut reaction is generally accurate. So if you think this patient's septic, treat him as sepsis. Think sepsis when the patient's got a fever, when the patient has altered level of consciousness. Any patient who's got an indwelling device, particularly if it's a Foley catheter or a dialysis catheter, patients had recent surgery, or any patient from the skilled nursing facility or ECF. Start fluid bolus and transport rapidly. Start pressors early. If the patient's hypotensive and seems to be getting worse, even though you've got fluids running, start the pressors. Call the sepsis alert. And for everybody, EMS, blood cultures, and antibiotics are on the horizon. So hopefully I've answered a lot of your questions about sepsis. If you have any questions, please post them on Basecamp, and I'll do my best to answer them for you. Thank you.